The topic of today's lecture is acute rheumatic fever. Now, what is acute rheumatic fever? It is a multi-system autoimmune disorder in which our body produces auto antibodies against group A streptococcal antigens. Now, these antigens are introduced in our body through bacterial pharyngitis, which is commonly called a sore throat. Now, there are various clinical manifestations and presentations of acute rheumatic fever, but two of those are noteworthy. One is arthritis, the other one is the carditis. The arthritis is important because the appearance of arthritis reduces the quality of life for that patient and it is very painful. The study of carditis is important because about 60% of all patients with acute rheumatic fever develop rheumatic heart disease further down their life because acute rheumatic fever is a pediatric disease. Usually, it appears around the age of 5 to 14 years old, and it is very uncommon to find acute rheumatic fever in a patient more than 30 years old. Now, in contrast to it, rheumatic heart disease is a disease of adults. It is usually found in the group of 25 to 40 years old because the patients of acute rheumatic fever develop rheumatic heart disease. Now, this was its prevalence. Now, as for its epidemiology, acute rheumatic fever is considered a disease of poverty. As with the developed country, there are less and less chances of a patient developing acute rheumatic fever, and it is very common in the developing country. Why? Because the environmental factors are very important in this disease. Both the overcrowding and the hygiene of the area where the patient lives along with his or her socioeconomic status are very crucial for this disease to both take hold and proceed through his or her life. Now, in order to understand the rheumatic fever, we have to understand its pathogenesis, how it takes its hold, and how it courses through the life of patient. Now, in order to understand it, we have a susceptible host. A susceptible host is one which has experienced sore throat or bacterial pharyngitis because now he or she has the group A streptococcal antigen in his or her body. Now, from here, if due to the environmental factors, especially the overcrowding, in which the bacterial pharyngitis spreads among the other patients and has its epidemic qualities, the patient might suffer from repeated group A streptococcal infections. Now, because the patient is having repeated and frequent and recurrent infections of group A streptococcal pharyngitis, the patient will suffer from the first episode of acute rheumatic fever. Now, this first episode is further precipitated if the patient already has a strain of group A streptococcal which contain its specific virulent factors. Now, these virulent factors are the M protein and the N-acetylglucosamine. The M protein is of special interest because it is the M protein which determines the serotype of the group A streptococcal. because the serotype 1, 3, 5, 6 are the most common and are the most culprit of producing acute rheumatic fever in a patient. Now, there are two theories as to how, after the patient has been exposed to the group A streptococcal antigens, how the acute rheumatic fever develops. One theory states that there is molecular mimicry between the group A streptococcal antigens and the host tissue. In other words, the M protein and the N-acetylglucosamine are also found in the cell membranes of our cells, and these molecules mimic the virulent factors of the group A streptococci. Now, because of this mimicry, because they are of the same structure, what happens is that there is an exaggerated T cell mediated immune response. An exaggerated T cell immune response is the one where T cells not only start to proliferate the area, but they also invade the area and damage that particular tissue. Now, this process can also be further increased if the patient is genetically predisposed to these conditions. The other theory states that the patient who has infection, a bacterial pharyngitis, due to the group A streptococci, these streptococci are actually themselves are invading and damaging the tissue of that particular organ. So instead of having some kind of mimicry between the virulent factor of the group A streptococci and the compounds found in our cell membranes, the bacteria themselves are doing the damage. But the theory containing the mimicry is the one that has more evidence to it. But there are some studies that also support that group A streptococci are also found in the areas of damage, especially the leaflets of endocarditis, which develops after the carditis event of the acute rheumatic fever. Now, after this first episode of acute rheumatic fever, the patient may develop rheumatic heart disease. Now, as I previously stated, 60% of the patients, the pediatric patients in their adult life, develop rheumatic heart disease. And this is precipitated by one either repeated or ongoing infections which possibly drive the inflammatory response to more higher levels, or the episodes of the acute rheumatic fever themselves become more frequent and recurrent. Whatever the case is, either the infections become recurrent or the episodes of the acute rheumatic fever themselves becomes frequent. The patient from his pediatric life to his adult life may develop rheumatic heart disease, and it is the rheumatic heart disease which increases the both the mortality and the morbidity of the acute rheumatic fever. Next, we'll talk about the clinical features. Now, like I said, there are many clinical features and manifestations of acute rheumatic fever. The two most common one are the carditis and the arthritis one. Here we'll talk about the heart involvement or the carditis. In the carditis, which then further develops in the rheumatic heart disease, what happens is that there is valvular damage. Now, In the heart, there are many valves which control the flow of blood from one chamber to another. The valve which is most susceptible to the rheumatic heart disease is the mitral valve. Mitral valve is a bicuspid valve which is found between the left atrium and the left ventricle. Now, because of the damage, either due to the proliferation of the T cells after the mimicry of the virulent factors, or due to the damage by the bacteria themselves, the leaflets of the bicuspid mitral valve undergo damage. And that damage can be seen histologically as microthrombi containing fibroblasts and platelets. So, the first thing in rheumatic heart disease that happens is valvular damage. Next, because of the valvular damage, there is regurgitation. Regurgitation means that there is reflux of the blood from the chamber in the opposite direction. Now, what usually happens, like in the mitral valve's case, that blood flows from the left atrium to the left ventricle. Now, if the mitral valve is damaged, what will happen that blood, instead of moving from the left atrium to ventricle, it will then rebound and then proceed to move back into the left atrium after it has first pumped into the left ventricle. This is called regurgitation, and mitral regurgitation is the most common presentation of rheumatic heart disease, along with aortic regurgitation. That is the regurgitation of the aortic valve. So, in simpler terms, it is the backflow in the reverse direction of the blood inside the heart in the chambers. So, all of this, the valvular damage, the regurgitation, then ends up in the myocardial inflammation. So, in this inflammation, you can easily see that there is not only proliferation, but rather it's an invasion of T cells inside the myocardium of the heart. Now, because of this proliferation of T cells and lymphocytes inside the heart, the functioning of the heart is compromised. Both its inotropic effect and chronotropic effect is severely decreased. Next, we'll talk about the echocardiogenic findings. Now, like I said, mitral valve regurgitation is the most common presentation of rheumatic heart disease. And this is what we find on the imaging. Now, if we perform a transthoracic echocardiogram of the heart in a rheumatic heart disease patient, we'll see that this is the mitral valve, and because it's a bicuspid valve, it has two leaflets. This is the left ventricle and this is the left atria. And because you can see that this mitral valve has undergone damage, these are not continuous, it is not blocking the pathway, and it is showing what is called an elbow sign, that it is showing because of the damage, it is showing an elbow sign, which is that it has turned over, that there is no proper closure of the bicuspid leaflets of the mitral valve. That this leaflet and this leaflet of the mitral valve are not closed properly because the thickening of this leaflet, and this leaflet has thickened because of the damage, because of the rheumatic heart disease. So the flow of the blood from the left atrium to the left ventricle is compromised. So what happens is that normally blood moves in this direction, but now because one leaflet has undergone damage, the blood will move into the left ventricle. Now before it is ejected into the aorta, it will then rebound and reflux back into the left atria. So the ejection fraction of that patient will be severely deprived and decreased because this is the regurgitation in the mitral valve, that the reverse flow of the blood in the opposite direction to what it should have been. Next, we have the joint involvement. Like I said, two most common presentation. One is carditis that we have just discussed. The other is the arthritis or the joint involvement. Now, in the joint involvement, what happens is the first one is the arthritis. What happens is that there is inflammation of the joints of the patient. Now, the joints that are affected are the synovial joints. These are the joints of the extremities, that is, the digits, the hands, the wrist, and feet. Then we have what is called as polyarthritis. Polyarthritis means that multiple joints are simultaneously affected, that multiple joints are showing signs of inflammation. But a common sign of polyarthritis in rheumatic heart disease is that it is of migratory nature, that the inflammation jumps from one joint to another, that it will move between the fingers, that it will inflame, let's say, inflame this finger, the index one, then the middle one, then the ring, and then the little one. So it will have a migratory pattern. Even though it will still be a polyarthritis, that it is affecting multiple joints, it will have a migratory nature to it. And because of this migratory nature, this characteristic is pathognomic and characteristic of rheumatic heart disease. Next is the arthralgia. Now, in any arthritis or polyarthritis, patient suffers from arthralgia. That is the pain when there is movement in joint. And in rheumatic heart disease, this is particularly interesting because the arthralgia is the one that increases with time. With time, because of the friction between the inflamed joints, it starts to increase until a time appears where the threshold has reached and patient cannot move any further. So arthralgia in rheumatic heart disease is special because it increases and doesn't stop at a particular area. It will keep on increasing until it will reach a threshold where the patient will not be able to suffer further. A very uncommon presentation of joint involvement in rheumatic heart disease is the aseptic monoarthritis. What we usually find is polyarthritis. Monoarthritis is not usually found in rheumatic heart disease, but there are a few cases documented which have stated that there have been aseptic monoarthritis in rheumatic heart disease. So, even if your patient has only monoarthritis, it does not mean that the patient has the exclusion of rheumatic heart disease, because monoarthritis may be septic, may be aseptic, but it can happen in rheumatic heart disease. That is the point I want to clarify. Polyarthritis is not pathognomic for rheumatic heart disease. The migratory nature of the polyarthritis is pathognomic, because we can see monoarthritis in rheumatic heart disease. Next, we have chorea. Chorea is a Greek word which means to dance, and it is described in medical terminology as irregular, jerky movement which is somewhat pointed and it is not repeated. Now, if we contrast it with other neurological problems, ataxia is the one where the movement of the patients are weakened. In Parkinsonism, the movement of the patient is hindered. That patient is unable to perform a specific movement. In chorea, what happens is that there is jerky, irregular movement, but that movement has a migratory nature, that it moves from one muscle to another. Let's say the patient wants to move its hand. Now, instead of a regular lifting of hand, what will happen that it will move like this. So because of this particular nature where the hand and the arm have a migratory nature to them, that the muscles move in a successive nature, this is what defines as chorea. And this is very different to both Parkinsonism and ataxia. Chorea in rheumatic heart disease is common. It is about less than 5% of the patients. Then we have the skin manifestations in such patients. Now, there are two types of skin manifestations in rheumatic heart disease. One is erythema marginatum. Erythema marginatum is a papular rash where the margin of the rash has an evanescent property to it, that it appears and vanishes in front of the examiner. Now, because of this nature, it is termed as erythema marginatum. That instead of having a diffuse margin, the margin is both appearing and disappearing, and this is creating a margin around the rash. And that margin is what is characteristic of the rash which is found in the rheumatic heart disease. Next, we have subcutaneous nodules. These subcutaneous nodules are small, painless, mobile nodules which are found and formed around the phalangeal joints in the patients of rheumatic heart disease. They are again pathognomic for rheumatic heart disease, that these nodes are only found in rheumatic heart disease. Next, we'll talk about the diagnosis. Now, there are major manifestations of acute rheumatic fever and minor manifestations of acute rheumatic fever. The major ones are carditis, arthritis, subcutaneous nodules, erythema marginatum, and chorea. The minor manifestations are fever, increase erythrocyte sedimentation rate, increase total leukocyte rate, and an increase in the uh, and decrease in the platelets. And there are also other supporting evidences such as positive anti-streptolysin O test. uh, these are what is considered as supporting evidence. Now, in order to diagnose a patient with rheumatic fever, we have to take into consideration the amount of the episodes and establishment of rheumatic heart disease. Now, if the patient has, we have to diagnose the patient with primary episode of rheumatic fever. He or she should have two major manifestations, or one major or one minor manifestation, along with evidence of a previous infection of group A streptococcal infection. If we want to diagnose the patient with a recurrent attack without an established rheumatic heart disease, again the patient must have two major manifestations, or one major and one minor manifestation with an established evidence of a previous attack of group A streptococcal infection. Now, if we want to diagnose the patient with a recurrent attack with established rheumatic heart disease, he or she must have two minor manifestations along with an evidence of a preceding group A streptococcal infection. Next, if we want to diagnose rheumatic chorea, it is done on a physical examination. And if we want to diagnose the patient with an insidious onset rheumatic carditis and chronic valvular lesions of the rheumatic heart disease, it is done on imaging, or specifically on transthoracic echocardiogram. Next, we will discuss about the recommended test. Now, for any case of acute rheumatic fever, we have to perform a few tests. One of those is white blood cell count, because it is one of the supporting evidences if we want to diagnose our patient. Then we have the ESR, or the erythrocyte sedimentation rate, which is one of the minor manifestations of the acute rheumatic fever. Then we have the C reactive protein. Now, this protein is always increased whenever there's inflammation present. And we know that acute rheumatic fever always has inflammation present in one form or another, either carditis or arthritis or subcutaneous nodules, whatever it is. C reactive protein is always increased in inflammation because it is a pro-inflammatory agent. Next, blood cultures if the patient is febrile. Now, fever is one of the supporting evidences when diagnosing a patient with acute rheumatic fever. And fever only occurs when the patient is undergoing bacterial pharyngitis or is having an attack of group A streptococci. So the blood cultures are only taken when the patient has fever. Next, we perform electrocardiogram. We perform electrocardiogram or ECG because there is an increase in the PR interval, which is one of the supporting evidences during the diagnosis of acute rheumatic fever. Next, chest X-ray. A chest X-ray may show cardiomegaly, may even show mitral valve prolapse, or even the thickening of its leaflet if it's done in a good setting, or if the chest x-ray is of digital nature giving more information. So chest x-ray is also done in order to give a whole proper view of the thoracic cavity. Then we perform the echocardiogram. Echocardiogram again is performed to confirm the diagnosis of the rheumatic heart disease, because on echocardiogram we confirm that which valve is affected, which leaflet, one leaflet, both leaflets are affected, and what is the extent of the damage. All of it is established on an echocardiogram. An echocardiogram for a rheumatic heart disease in after an acute rheumatic fever is done via transthoracic way. Next, a throat swab. Throat swab again is done if the patient is having an acute attack of group A streptococcal, or if the patient simply has a sore throat. A sore throat after an attack of acute rheumatic fever usually means a recurrent group A streptococcal infection. So, a throat swab will tell us that there is group A streptococci present, and the patient is having frequent episodes of this particular bacterial infection. Then there are certain tests which can be performed to check the presence of the group A streptococcal activity. One of those is the anti-streptolysin O test, or the ASO test, or the anti-DNA ACE test, which is all done, and if found positive they give a positive indication of the presence of the group A streptococci antigen in our blood. Next are the recommended tests that depend upon the clinical features. Now, they are not for everyone, for every patient of the acute rheumatic fever. These tests are dependent upon the clinical features which are found on the physical exam. Now, they can be repeated blood cultures if an endocarditis is found, because we have to make sure which is which kind of bacteria is the culprit. Most commonly, it is Streptococcus viridans, but sometimes there are other bacteria which might cause endocarditis in a patient. So, we repeat blood cultures in such patients. Then, joint aspirate for a possible septic arthritis. Now, like I said before, polyarthritis, a migrating polyarthritis, is what we usually find in an acute rheumatic fever. But sometimes these arthritis, if presented in a monoarthritic way, can get infected, and if they get infected, they will result in a septic arthritis. So, a joint aspirate is done only if the joint of the patient is found to be not only swollen but red and extremely painful. Next, we perform the test of the serum copper, ceruloplasmin, anti-nuclear antibodies, ANA, and drug screen for the choreiform movements. Now, all of these are done in order to confirm that if there is any increase in the copper or ceruloplasmin inside the body, in order to exclude the diagnosis of the Wilson's disease in such patient, because Wilson's disease also result in chorea, in dementia, and other such symptoms which may overlap with acute rheumatic fever's neurological manifestations. Next is the serology and autoimmune markers for arboviral, autoimmune, and reactive arthritis. Now, again, this is only done if we have some kind of notion of the, or if there is some kind of epidemic where the arbovirus is common, or we have some kind of evidence that we should perform this test. It is only done in highly specialized cases where either there is an epidemic or the patient lives in an overcrowded place which has the history of an arboviral outbreak. So, this is how it is done. Next, we'll talk about the treatment. Now, the treatment of acute rheumatic fever is done via a variety of ways. One way we can do it is by giving the patients antibiotics. Now, antibiotics are given because we know that damage is being done by the bacteria. Now, once we know which bacteria is responsible, now we know that it is a group A streptococci, but there are many group A streptococci. Now, once we know which kind it is, we can perform a culture and sensitivity test and give antibiotic accordingly. So the antibiotics which are given usually in acute rheumatic fever are phenoxymethylpenicillin, which is given 500 mg to 50 milligram for the children per oral twice weekly. It is a special kind of penicillin which is only given twice daily, and it has to be given orally. Another type of penicillin that we can give is the amoxicillin. It is given in the 50 milligram per kg body weight with the maximum dose of 1 gram. It is given daily for about 10 days. Usually it is given in divided doses. Next, we have single dose of 1.2 million unit or 600,000 units in case of children of benzathine penicillin G. Now, benzathine penicillin G is of special interest because it is given not via the IV route but through the IM route, that is the intramuscular route. That is why it is given not as milligram but as units. Another way we can treat the patients, which can be done either in isolation or concurrently with antibiotics, is the prescription of salicylates and NSAIDs. NSAIDs are the non-steroidal anti-inflammatory drugs. They include the aspirin. Aspirin is acetyl sulfosalicylic acid, which is given 50 to 60 milligram per kg body weight per day. Now, this is a huge amount of dose to be given for any person, because if it is properly calculated, the dose ranges from about 4 gram to 6 gram, and in this range the person has to be monitored for any kind of symptoms for salicylate poisoning, especially if the patient is showing any kind of imbalance in the acid base system. Another NSAID that we can give is the naproxen. It is given 10 to 20 milligram per kg body weight per day. Again, it is a huge amount of dose, and again the patient must be monitored very carefully for any kind of symptoms or signs for toxicity or poisoning. Now, will come for the treatment if the patient is suffering from congestive heart failure. Now, because acute rheumatic fever develops into rheumatic heart disease in about 60% of the patients, and those patients have valvular damage, and because of the valvular damage and regurgitation, the heart undergoes congestive failure, that there is congestion of the blood inside the heart, which is the heart is unable to pump out, and because of this the heart fails. Now in this case what we do is that we prescribe prednisone or prednisolone, and it is given about 1 to 2 milligram per kg per day with maximum of 80 milligram. Now, the efficacy of glucocorticoids in congestive heart failure is contested, and few books even find it controversial. But it is given in patients in hope that because glucocorticoids decrease inflammation rapidly and in a very dramatic fashion, that's why in congestive heart failure, prednisone is given. And it is noteworthy that it is only given only for a few days or up to only 3 weeks, because after that the dose is tapered off if it is not giving any effect, or if its efficacy is lost on the patient. Next, we have the treatment for chorea. We discussed the treatment for carditis. Now it's time to discuss the treatment for chorea. Because chorea is of neurological origin, its treatment is remarkably different. It is treated either by carbamazepine or through sodium valproate. Both of these are anti-epileptic drugs. So if the patient is also suffering from epilepsy along with chorea, this will also help. So chorea in the patients with acute rheumatic fever is dealt with these drugs, the carbamazepine and sodium valproate. And these two are anti-epileptic drugs. Prednisone or prednisolone has no role in the treatment of chorea. It has only some role in the treatment of the congestive heart failure. Next, we will discuss about the other options during our course of the treatment. Now, if the patient is suffering from heart failure, whether it is congestive or restrictive, whatever the case is, the proper guidelines have to be followed. So the management of the heart failure is done according to the guidelines. Then the patient is also advised bed rest. It has been observed in many studies that bed rest for the patient of acute rheumatic fever and rheumatic heart disease, bed rest has given remarkable results. Then there is the intravenous immunoglobulins. Now, because acute rheumatic fever is an autoimmune disease, and because the body is producing auto antibodies, we can replace those auto antibodies with regular antibodies. Now, it is an expensive procedure, but it has its efficacy, and and if the patient is suffering too much, if the quality of life is hugely disturbed, this treatment option has huge benefits for those patients. Next, we'll talk about prevention and prophylaxis. Now, we have a patient with first episode of an acute rheumatic fever. Now, what we can do to prevent another episode of an acute rheumatic fever. Now, the primary prevention lies in the environmental change. We have to change the environmental factor of the patient. If the patient lives in overcrowded home, that has to change. If the hygiene of the patient is compromised, that has to change. The patient has to be hygienically adept. The secondary prevention lies in medication. So, the medication that we give for secondary prevention of subsequent attacks of acute rheumatic fever are benzathine penicillin G, which is given every 4 weeks. Now, because it is prophylaxis, that's why this penicillin is given every 4 weeks. Or we can give oral penicillin V twice daily. So if the patient is intolerant or has reaction to the penicillin, then we can always give the patient erythromycin 250 milligram twice daily. So if the patient is intolerant, erythromycin can also be given instead of the penicillin. So these drugs comprise of the secondary prevention or prophylaxis in case of acute rheumatic fevers episode, because the primary prevention lies in the changing of the overcrowding and the hygiene of the patient. So, this was the lecture on acute rheumatic fever. We discussed what acute rheumatic fever is, what its common manifestations are, why arthritis is important, why carditis is important. We learned about the carditis, we learned about the rheumatic heart disease, we learned about the pathogenesis of all of it, we learned about its treatment, how to treat the acute rheumatic fever, how to treat the rheumatic heart disease, what we do if complications arise, and how to diagnose rheumatic fever in if the primary rheumatic fever, if there are recurrent with rheumatic heart diseases, and which kind of imaging and tests are performed in which kind of acute rheumatic fever's diagnosis. All of this was discussed in this lecture. Thank you so much for watching sqadia.com.